Hi there, welcome from wherever you've joined in. My name's Ben King. I'm one of the cardiologists and electrophysiologists at Genesis Care and Fiona Stanley Hospital. My topic today is family matters. It's a growing area in cardiology, and I'm sure in other areas of medicine, that family screening has become a area of sensitivity, both with regards to many aspects of health, but also the more exact science of genetic medicine. WA has a small but very highly skilled and very well resourced genetic services team, and there is an inherited cardiac disease service, and this will talk to several aspects of that service, but more relevantly speak to what we as clinicians, both myself in my consulting clinics and you in your clinics and departments will come across, and perhaps in the future think about a bit more when you see one patient and think about the rest of their family. I'd like to divide the talk into three main parts. Those regarding inherited cardiomyopathy, inherited arrhythmia, and there's a significant overlap between those two, and touch on perhaps not in great depth with regards to the biology, but the most commonly inherited disease that ends up as cardiological disease, which is dyslipidemia. Let's begin for a moment with the, one background point about genetic medicine. Now, when it is simply Mendelian inheritance and that you have dominant or recessive and it's easily mapped and what have you, then the family tracing is to a degree more simple, and we refer to cystic fibrosis and Huntington's disease and these types of conditions. But of course, the genetics have a far wider reach into the community and into different types of medicine in a manner that's not always that easy to trace and demonstrate, because we'll see families in whom the genes are common, but the disease is very variable. We see that one person might be affected very severely, unfortunately. One person might have minor manifestations, and one person who has the gene, in fact, may not express the disease phenotypically in any manner at all. And there are a number of factors in play. Of course, there's the environmental factors, those that the person has acquired well after acquiring their genes. And then there are other genes affecting that gene. That's the study of epigenetics, and I'd like you think about it like this. Gene in position number 1 codes for the disease. However, gene in position number 2 affects gene number 1 by making it express more disease. Gene in position number 5 affects gene number 1 by making it express less, and therefore the disease has less severity. Gene position number 7 affects number 5 by making it more upregulated, and so on and so forth. And clearly the mathematics is indefinite and thankfully managed by people smarter than me, but that's one explanation. But within known abnormalities of genes, it's not always clear how pathogenic the problem is. So a normal gene is a useful finding, and equally useful is a gene that we know with great sensitivity and specificity is associated with certain conditions. But there's a vast raft in the middle in which it's abnormal from a genetic sequencing perspective, but the clinical significance is unclear. And as this is a growing science, and as we have more time with it and more numbers collected and longer follow-up and collaboration between multiple centres around the world, and that's really important, we may be able to reclassify some of those genes in 1 year or 10 years' time as being clearly not a problem, or clearly much more of a problem. For instance, the gene's been mapped 5 times, in whom 2 we've seen the disease. Now that's highly suspicious, but if you then get it mapped 200 more times and see no one in the disease, then at that percentage it might fall back into a baseline population risk and be reclassified as not being a problem. And the opposite can be true as well. So with all those shades of grey in mind, let's move on to 3 cases into more concrete ways to view I would call it inherited medicine as opposed to genetic science. The inherited cardiomyopathies can be divided in a number of different ways, and for convenience more than any, I've divided it into 4. Hypertrophic cardiomyopathy, that is a disease of abnormal muscle cells. The sarcomeres are microscopically and functionally and electrically all abnormal, and that should be distinct from someone who has hypertrophy, because that can be age and high blood pressure and obstructive sleep apnea, a number of different explanations. That's our job in distinguishing what type of disease, because if it's the former, the true inherited disease, then genetic screening is very useful, and if it's the latter, well, then you need to look upstream. Dilated cardiomyopathy, that relates to the fact that usually the dimensions of the heart are much bigger, as well as the systolic function being poor. That's not diagnostically vital. We're talking about a diffuse disease of the heart muscle that is not explicable by myocardial infarction, previous viral infection, so on and so forth. Arrhythmogenic cardiomyopathy, formerly known as arrhythmogenic right ventricular cardiomyopathy, is a fairly rare disease that doesn't have any gold standard testing, apart from perhaps a positive myocardial biopsy, which we don't do that much of. It's a disease that has a very clear genetic component. It can present in most patients with ventricular tachycardia or lots of ectopy, in some patients with heart failure. It does tend to affect the right more than the left, but can affect really any part of the heart. The key feature in this one is that it commonly presents in young age, and that exercise not only provokes arrhythmia or increases the risk of arrhythmia, but in fact accelerates the pathogenesis of the disease. So it's a pretty important diagnosis to make. And then there's the fourth category I have on the slide here is a heterogeny that we won't really touch on very much. Restrictive cardiomyopathy, amyloid, which is protein deposition causing thickening and weakening of the heart, a proportion of which is inherited. That's called transthyretin or TTR. Non-compaction is rare again, and I think we'll just leave that aside for the moment. Let's talk about a case. These cases, I should preface, are based on patients of mine, and I have deliberately changed enough detail so that they won't be identifiable, or at least not without a lot of effort. Mrs. JK is a 46-year-old who's quit smoking quite a long time ago, somewhat overweight but not terribly so, and has impaired fasting glycemia. It presents with a fairly subacute syndrome during which you become progressively short of breath over months. Midway or after that process, developed orthopnea and PND, and was just tired because she wasn't able to sleep because of this. There's plenty of family history in JK's family. She lives down in the south of WA. The family is Noongar and Yamachi, and there's some Anglo-Celtic ancestry on the dad's side. And the family history is key here. The son in his 20s has already passed from, quotes, heart failure, or congestive heart failure, pardon me. Daughter had a transplant. Brother died relatively suddenly, but had noted to family members that he'd been breathless leading up to that. No post-mortem. Another brother is breathless, and I have subsequently seen, but was to see me at that stage. It's a big family, and she said she's pretty sure that there are other people with some similar problems. Now, we could pause there, but I'm going to include her examination and then double back and contextualize that history. So she's borderline tachycardic, in sinus rhythm. Her blood pressure is slightly high, maybe a stress response, but her JVP is high. So her right side's fluid overloaded. Her heart sounds are normal, but she's got a mitral regurgitation murmur, which you commonly find as a functional consequence of heart failure without being a primary cause. And she has crackles and swollen ankles. It's a garden variety heart failure presentation. Now, if we pause for a moment and say 46-year-old Australian, the most common cause of heart failure is probably ischemia, and close behind them would be alcohol, and then you're looking into the rarer things, hypertensive cardiomyopathy, valvular, indeed, in certain areas, WA, I see a lot more valvular than perhaps in the south and in the city. And all of those things can run in families. Ischemia runs in families and is common in this age group. But you'd be a bit suspicious that a son who died in his 20s, that's really young for any ethnicity, and a daughter who had a transplant, similarly young. Number one, that's a peculiar finding. Rheumatic heart disease for sure runs in families, but although the genetic component perhaps isn't as explicable, so on and so forth. But I think that the antennae that would pick up traceable genetic disease should already be twitching. Not long after, really shortly after this woman leaves the clinic, the Aboriginal health worker comes into my room and says and explains that there's a far bigger problem in this family than I'd been alerted to. That there were many people who were not old, middle-aged, who either had early symptoms or were fearful of developing symptoms and essentially locking up. This is long before coronavirus. Were locking themselves in home, feeling like the inevitable bad outcome wasn't far away. And so we started to investigate JK just in the rooms. The ECG showed this. She's in sinus rhythm or borderline sinus tachycardia. Got a very broad left bundle branch block, which is not at all specific regarding cardiomyopathy. It doesn't tell me which type it is. There's one extra note that it's subtle but for the trained spotters like myself, that the axis is quite high, sort of superior or vertical, and that actually portends a slightly lower or worse mortality or outcome. However, that's usually when there's low voltage in the limb leads, which we thankfully don't see here. Some other tests, there's a degree of mild renal impairment. That's relatively new. I did a broad biochemical screen for her cardiomyopathy. So her iron is normal, so it's not hemochromatosis. That's a rare cardiomyopathy. QEP and light chains attempting to rule out the amyloids, but not TTR amyloid. That would be done with a different test, which is in fact a bone scan. ANA, ENA, and ANCA, looking for autoimmune or vasculitic causes, normal. And the echo, not surprisingly, showed dilated global impairment of the heart, which suggests it's not ischemic, but of course multi-vessel coronary disease can give global impairment. EF's 24. The mitral valve itself is normal, but it's moderately leaky, and that's a consequence of the LV impairment. And therefore you treat the LV, not the valve as a rule. And the angiogram did not demonstrate obstructive disease to cause her heart failure. So we begin on heart failure treatment with some furosemide and some ramipril for vasodilator. She had pulmonary edema. I don't want to bring in my beta blocker too early. GTN patch is a good symptomatic fix, but it's not a prognostically important thing. And of course, as important as anything is that patients need to go home and manage themselves very well. They need to be net negative in fluid, and that's going to involve fluid restriction orally and increase urine output really with furosemide. Salt restriction is to reduce the fluid retention, and they needs to be monitored at home. Daily weights, depending on the patient's size, I would say 1.5 day-to-day increase should warrant review, because it probably means fluid overload, or a week-to-week of 4 kilograms, roughly speaking. And JK responded very well. 2 weeks later, she's no longer in pulmonary edema. We could stop the GTN, still had plenty of blood pressure to increase the ramipril. I added a beta blocker. Another 2 weeks later, and I think 2 to 4 week reviews, depending on how sick they are, is about right. Increase the beta blocker more. The blood pressure was about right, so we're not going to go to the nth degree on the ramipril. Change her over to Entresto, which is sacubitril valsartan, that has fairly well documented marginal gain above the previous therapies, and add spironolactone. And repeat echo after maximising and up titrating and giving enough time for medicine shows, in fact, she still had impairment. So we went on and implanted her with a cardiac synchronization defibrillator. The cardiac synchronization has proven several benefits, like survival, hospital presentations, patient function, patient symptoms in severe LV impairment plus left bundle branch block. The role of the defibrillator in non-ischemic cardiomyopathies has recently been questioned, but in a patient as young as 46, I think it remains. And so she got the full box and dice. X-rays pictured here. And the ECG is the biventricular paced rhythm. It's really narrowed up a great deal. And that is one of our targets that predicts a good outcome. And sure enough, that's what she was lucky enough to experience. EF went to nearly normal. At 49, your prognosis is excellent and your symptoms are likely to be excellent. And sure enough, she's New York Heart Association class 1 now. She's on the middle dose of Entresto, maximum dose of beta blocker, not very much furosemide, back at work, exercising, lost weight, doing really, really well. Now, I've seen the brother. The brother was pretty similar, not as bad. And a nephew comes, and he has a mild version of the same thing. He's got a left bundle branch block. He's got mild to moderate, probably touching moderate LV impairment, and his symptoms aren't as severe. And we're looking now at 4 first-degree relatives involved. We're now bringing in some third-degree relatives. The incidence is really quite high of heart failure syndromes within the family. And so we've got to try to demonstrate the family that these guys were kind enough to have somewhat of a family tree of their own, which was helpful. And the way you go about testing from a genetic perspective is you take the proven index case and you do the genetic map them. It's a slow process for a number of reasons, for batching and for actual processing. But when you find a pathogenic mutation in that patient, rather than doing the broadest of screens in the whole family, you can make a much more specific approach, and you start with the first degree relatives and those that demonstrate. Then you go on and screen their relatives in so-called Cascade Screening. And where does this come into GP land? Actually not just GP land, come into community medicines, to clinics and hospitals all over the place. The key is that the genetic test defines the genotype, and our job is to define the phenotype. And not only that, but is to organise adequate surveillance for those people who have the gene, or clinically define those in whom we haven't had testing. Sometimes it's simply difficult to engage the family. They may not be your patients or live in your location, and therefore you're shifting a difficult responsibility back onto your patient who's just dealt with their own illness, to try to engage the family members and ask that if they feel it's okay to have their genes tested, particularly when they're young and well. And there's all sorts of stresses and stigmas involved there. And the reason why JK is a great story is because there'd been some horrible outcomes in this family, and they were all very, very scared. But moreover, when you can turn around and say, this is a disease that when detected and treated with medicines and implants and all the rest actually had a really fantastic outcome, suddenly there's plenty to protect, and the engagement went from fearful at home to serially attending the clinic and doing quite well. I should add that there's another, I think, a cousin in whom it also responded magnificently to biventricular pacing. So that's perhaps something that we can look at with the genetics guys. The inherited arrhythmias. This is even more interesting for me. There are many, and some are similar in some ways, but as a rule, it's the ion channels in the cardiac myocyte that pump the salts in and out during the action potential. The genes coding for them, when inherited abnormally, can give arrhythmia. And there are many potential provocations, classically medicine, and that whole idea of acquired long QT syndrome, drug-induced long QT syndrome that we trained in, we're sort of realizing that's probably second insult type arrangement, and a lot of those people had a very mild, like a Fourmé-Fruste abnormality of their natural QT physiology that's then provoked by their antibiotic and antipsychotic and whatever else. Brugada syndrome is genetically a little harder. Short QT, idiopathic VF, and CPVT are all rare but very dangerous, very, very dangerous. And then there are some patients in whom they have a familial tendency towards bradycardia and conduction disease, with or without structural abnormalities. So there's the Holt Orams and then there's the not. We won't talk too much about that. This is a nice case from this DM, a 24-year-old student and a representative athlete. Mild anxiety disorder, very well managed on an intermediate dose of sertraline. Because of athletic prowess, had an ECG at 24 years of age, about to travel internationally for netball. And naturally, there's no symptoms here. She's extremely good exercise tolerance, never had palpitations, never had a dizzy spell, never blacked out, doesn't smoke, barely drinks, never used drugs, has to test for the team, never used performance enhancing drugs, doesn't take supplements, super ostensibly healthy well. Not only that, both parents and all siblings have been wonderfully accomplished athletes as well, and none of them had any symptoms or any situations that are suspicious. And at this point, I'd like to raise a couple of situations that are worth asking about, even though it's uncomfortable. This is a relatively new bit of science, and if we were talking about it in 1960, we wouldn't say, does anyone have a defibrillator? Does anyone have an arrhythmia or a long QT? But what we might be able to say is, has anyone crashed a car sober? Has anyone had an industrial accident? Has anyone drowned who knew how to swim? Has anyone had cot death? And if they've happened in the family, it's an uncomfortable conversation, but they're the circumstances that we might retrospectively fit a syncopal episode into, and it's worth asking. So DM was bradycardic because she's athletic, she had normal blood pressure, her cardiovascular examination was totally normal. She attended with a team trainer who said, well, if we're going to travel and we're going to push her very hard as an athlete, we need some written clearance for that. And just to make it better, international selections were being done in the next 2 weeks. And this was the screening ECG. If you stand far enough away, that looks fairly normal. I want to draw your eyes towards a couple of things, and I'll bring my mouse in here. The first thing is this inverted T wave. Inverted T wave in V1 is commonly normal, probably 3/4 roughly. Inverted T wave in V2 is commonly abnormal. About 30% probably are normal, and it does tend to be young women, the so-called T wave inversion of adolescence. But it needs to raise a couple of questions. One is, in fact, ARVC, and the other one is just ion channel abnormality. So now we go on and measure the QT. The QT raw is from the beginning of the QRS complex, not until the T joins the isoelectric line, but if you take the steepest part of the downslope, or upslope if it's inverted, you draw a tangent to where it meets the isoelectric line. So it will be a touch earlier in this one, but it is really quite long. Even when you adjust for bradycardia, it is longer with slower heart rates. That's normal physiology. But even when you adjust, it's over 500. So that's really quite long and into a higher prognostic group when it's over 500. The resting ECG is not as sensitive as doing a exercise test, or in people who can't exercise, there's a proxy which is standing and lying. But sure enough, the exercise test was distinctly abnormal. This young woman has long QT syndrome. And so we started her on nadolol. That's the beta blocker of choice. It's not available on PVS, but it's available on SAS. There are other beta blockers that are reasonably effective as well. But the best evidence is with this, and we want the best for this type of patient. And you want to get up to about 1 milligram per kilogram. We started low. After a couple of days, we jumped it up to full dose. And sertraline is an issue. All of the SSRIs/SNRIs, the antidepressants, are prolonged QT to an extent. Some more than others, and truthfully, sertraline, I believe, is the least provocative. So we need to be careful to manage her anxiety, but on balance, she really needs to try to have life without an SSRI. So she's a very stoic young woman, tried the full dose of Nadolol, just didn't get on with life, very lethargic, couldn't, even run like you and I would run. Felt hungover for no good or deserving reason, and so we agreed to go back down onto the half dose. But the repeat exercise ECG was very encouraging. The degree of beta blockade was good, so we can have a look at the heart rate profile. And in fact, the recovery QT looks much, much better. This is it demonstrated, and whereas before it was probably 2.5 big squares almost, here we're about 2. So that's a meaningful improvement. So she gets back into training, and it doesn't quite feel right, but is able to build through this. On the consult, her sister attends, also an elite athlete, and the discussion begins. Is this inherited? Well, yes, and the question is it a spontaneous mutation or is it inherited from mum and dad, all of whom have been through all the rigors? And so, again, we take our index case, who's DM, that's ECG, and we send for genetic analysis for the ion channelopathy screen, and she comes up with the sodium channel KCN, which is a long QT type 1 abnormality. And we go out and make a family pedigree. Here, we're talking about clinical manifestations and not genetic ones. So this is the QT, this is the symptoms, syncope or aborted cardiac arrest, and whether they've gone on to have an ICD. ICDs are thankfully quite rare in this group now. Beta blockers are vital. They can participate in exercise. It's not the worst disease for exercise. You do need to counsel the patient extensively on what the risks, not just of exercise, but other aspects of the disease, and they need to make their own decision. And some will say, this isn't for me, and some will say, I get it, I'm going to keep playing, and we'll stay under close control, and the odd one becomes a challenge. There is potentially a role for a loop recorder. I mean, the question is, are we going too slow? Do we need a pacemaker, which we certainly want to avoid at 24? Are we doing a job? Are we suppressing non-sustained polymorphic VTs? Because if they're there, then we know we need to change something, more beta blocker, sympathectomy, or maybe even an ICD. But really, the ICD type things are for secondary prevention. If the patient has had syncope or expressed malignant arrhythmia or whatever else. And now I changed that title a little to Inherited Ischemic Heart Disease. We can think about the familial factors of ischemic heart disease in many ways. The way that we need to perhaps increase awareness is the familial hypercholesterolemia, FH, and that's a growth area, an area very, expertly serviced in WA. But of course, smoking and eating pies, it runs in families for a non-genetic reason, and we need to keep that in mind as well. There are many non-cardiac diseases that contribute aggressively towards cardiac disease that definitely run in families. Systemic inflammatory diseases like rheumatoid arthritis have very, very distinctly increased risks of all types of atheromatous disease. And then there are other rare, honestly, connective tissue disorders in which you can have things like spontaneous coronary artery dissection, and that can run in families as well. And then there's the metabolic syndrome, the patients who, for genetic reasons, have dyslipidemia and hypertension and insulin-resistant type 2 diabetes that run in families without necessarily going through the genetic testing. That's possibly the most common contribution here. So let's talk about Mrs. TG, a 74-year-old retired office administrator who has hypertension quite diligently and effectively managed as a rule, dyslipidemia, but never had any symptoms. She had been away, again, this is a non-coronavirus context, had a chronic cough well after coming back, and so she had a high-resolution CT scan of her chest, and there was an incidental finding of 3-vessel coronary calcification, and was referred in for what's essentially primary prevention consultation. And the family history had it all. Her father had an MI at 35 and a bypass at 60. Her father was one of 4. The 2 uncles and 1 aunt all had ischemic heart disease diagnosed in their 40s, and in fact, some of their kids had already, some first cousins from the paternal side had also had ischemic heart disease at a very young age. She herself was a non-smoker and a non-drinker and a fairly avid exerciser. She either goes for a walk or does folk dancing for an hour pretty much every day. She had normal heart rate, slightly elevated blood pressure, but she was noticeably agitated. Her home blood pressures were a bit better than that, but perhaps not ideal. And the examination was only significant for an early peaking ejection systolic movement. It radiated little to the carotids. The pulse seemed fine. If it was a stenotic aortic valve, it was very mild. And her main interest was in the family. So she wanted to prolong her own life, grandkids, but in particular, her 2 sons who were about my age, and 4 grandkids. She was aware of this family tendency and wanted to avoid it. This is her ECG, which is normal. Not quite voltage criteria for LVH, and she has a normal build. The echo showed, in fact, the aortic valve was sclerotic, so a bit thickened, but functioned normally. Her lipids from if you were scanning through too quickly were actually okay. Now let's look at that very closely. That LDL is population normal, but it's not high risk population target. That would be less than 1.9. But that's her LDL on maximum dose of the maximum potency statin, rosuvastatin, plus ezetimibe. So in conventional lipid control therapy, she's maxed out, and she's only just in population normal. And again, that's one of these antennae issues, that she's probably an FH heterozygote. So we want to really optimize every single aspect of her cardiovascular care, because we think that there's some really elevated background risk here. So she was already on amlodipine ramipril combination. I just increased the amlodipine component from 5 to 10. We added aspirin, having seen coronary disease. Bisoprolol, which you could probably argue, and she got evolocumab. Now that was a little bit of a discussion that took 2 consults about further lipid reduction. And the point about TG's circumstance is that I'd encourage these patients that one of their clinicians go through the Dutch Lipid Clinic Network score. It's available online and calculated, and on atheroma.org.au. You can do it very simply. It looks into clinical characteristics of the patient, lipid biochemistry of the patient, and of first-degree relatives. So there's end organ issues, heart attack and stroke. There's also cutaneous manifestations of cholesterol deposition, and that is corneal arcus, which is a common finding in aged populations, but abnormal in the middle-aged, and xanthillomata, which are lipid depositions in the eyelids and sometimes on the tendons as well. By the way, a score of 8 or more is regarded as a definite syndromic diagnosis of FH. And again, we'll go through the family. We can draw out a family pedigree and test our index case, who is Dean herself. And there was by the way, this is commonly a polygenetic determination, but in fact there was an LDL receptor gene abnormality. And if I recall, her LP little a, her lipoprotein A was normal, which is interesting. And how do we clinically screen the family? Well, we can genetically screen the family, but clinical screening is going to talk to other aspects of their care. As far as I know, the boys, one of whom lives in WA and one does not, have not yet had any genetic analyses, but they've had their lipid profile and they're adverse. They're averse, and I've recommended, not having seen them face to face, that they actually have primary screening with CTCA, because I think that there would be indications beyond simply statin or lipid-specific therapies that they're probably already at 40 odd years of age have coronary disease sufficient for aspirin, for an ACE inhibitor or angiotensin blocker, and the entire suite of contributors towards premature ischemic heart disease need to be scrutinised at the utmost. And they're the patients who probably I would recommend regular home blood pressure monitoring, and I'd ask them to demonstrate dietary and exercise factors, and test them for markers of sugar metabolism and what have you, even though ostensibly they wouldn't be at great risk. All those things that are manageable need to be managed. And sure, diet and exercise needs to be encouraged. It has benefits outside lipid biochemistry, and truthfully, the benefits visible in the lipid biochemistry are quite subtle and usually insufficient. But that shouldn't mean they shouldn't be done. They should be done as well as pharmacotherapy. If necessary, for patients that don't do statins, there are, by the way, a number of trials on statin intolerant patients, but there are some nutraceutical options. And then the role for surveillance stress testing is controversial. It's not been demonstrated to affect mortality, etc. The difference is this: a patient who has ischemic heart disease has clear prognostic benefit from statins. That's huge. It's more than a third reduction in death rate, depending on how long you follow them up. Aspirin's pretty good. The ACE inhibitor data is long. If they have ischemia or if they have LV impairment, the beta blocker prognostic protection is very impressive. But what about revascularisation? Most patients who receive stents and bypasses, stents in particular, do so for very important reasons, but it's pretty much to improve their lifestyle without knowing scientifically that we're prolonging their life. But it does happen, and it happens in my practice probably a couple of times a year, that a patient will have a asymptomatic screening test, maybe for work, maybe for family history, or whatever, that is abnormal, and sure enough demonstrate the nature of coronary disease for which stents or bypasses, probably more commonly bypasses, truthfully, we believe would prolong their life. So can we pick that up with serial stress ECGs or stress echoes in these patients? That's probably an answer that we would scientifically come to at a later date, but we lack the data at this moment. But I think some form of assessment, either CTCA, not just calcium score, or non-invasive stress testing at intervals probably has a role if the patient risk is high enough. And certainly in the homozygote familial hypercholesterolemia patient, it's very important, because almost all of them will infarct or have revascularization in young life, not even in midlife. And so my takeaway is that much of heart disease and many heart diseases have a component of genetic predisposition or genetic abnormality. And so that is not a modifiable thing, but it's something we need to deal with and identify and scrutinize all our modifiable risk factors. But the broad communal responsibility is not only to stop at the patient that's in front of us, but to engage the patient and their family in screening their relatives, because these things can run in families quite a lot. Thank you very much. In the absence of an interactive session, if you have any questions, comments, queries, my email's there on the bottom of this slide, and look forward to hearing from you.